Her story is why advocacy, inclusive of the most negatively impacted communities, is critical. Many of you are participating in one or more of the 3 high-level meetings on public health taking place this week: the high-level meeting on pandemic preparedness and response, tomorrow's high-level meeting on universal health care coverage, and Friday's meeting on tuberculosis. One of our goals from today's event was to remind political leaders that ideas being discussed at these high-level meetings are critical to engage civil society in defining action and follow-up at the country level. And action must include the adoption of public health policies that are crafted to redress long-standing health disparities. Yet, policy change is often an underutilized public health tool, but it is critical to complement health systems reforms, disease management protocols, drug availability, and healthcare worker investments. Why? Why, you ask? It is the most efficient and cost-effective way to achieve population health impact, but it also remains underutilized, understood, and neglected as a critical tool. Public health advocacy ensures, 1, that urgent public health policies get prioritized and financed, and governments are held accountable for their implementation. It ensures population-level impact, making sure that it is possible, and if conceptualized effectively and narrowly, it prevents the further exacerbation of health disparities. And finally, it ensures that essential voices like Zuleika's have a seat at the table. So many of the World Health Organization's best buys and recommended interventions for prevention and control of non-communicable diseases are focused on health policies, whose adoption leads directly to improvements in health outcomes. Implementing plain packaging and graphic health warnings for tobacco products leads to increases in quit attempts by smokers. Front of package labels on food better inform consumers so they can make healthier food choices. Legislation and regulations banning the use of industrial trans fats in the food chain improves cardiovascular health outcomes. And adopting helmets, speeding laws, and child restraints reduces death and disease from car accidents. At the Global Health Advocacy Incubator, our work is grounded in our belief that public health improvements requires public health advocacy. Having supported public health advocacy in every region of the world, in big countries, in small countries, in island countries, in open political systems, in more restricted political systems, we have seen the power of advocacy to change policy and save lives. So we want to hear from you. We're looking forward to opening up the discussion after we hear from our panel. But in the meantime, we encourage you to post your thoughts on social media with the hashtags. Are you ready? At Global Health Advocacy, at UNGA 78, and please tag us at Incubator GHAI. Now, I am honored to be joined by a member of Parliament from Bangladesh, Mr. Sabri Chaudhry, who will provide some opening remarks. Mr. Chaudhry has a distinguished track record in public service spanning 2 decades, and he has been a vocal advocate for tobacco control and other public health issues in Bangladesh. He is here participating in the UN General Assembly this year as the special envoy to the Prime Minister of Bangladesh for Environment, Forest, and Climate. He is a friend of the Campaign for Tobacco-Free Kids, and I'm honored to invite him to the dais to provide opening remarks. Mr. Chaudhry.
Thank you, Yolanda, for that very kind introduction. I wish, though I was a Minister of Parliament, it should actually be a member. So let me set that right at the at the beginning. I know you have just come back from lunch, so let me extend warm greetings to all of you from the Prime Minister of Bangladesh and, of course, the people of Bangladesh. Rather than go through a written speech, I thought I would share, some thoughts with you as to how I got into politics and what drove me to the point where I started engaging in public health. So I got elected to the parliament in 1996. And, when you get elected, you are elected by a constituency. So there are people within a defined area who vote for you and you get elected. So after that, the question that came to my mind is how do I engage with issues which are important to me, but which transcend my constitutional boundaries? And that's when the idea of a constituency of issues came up. So when we talk about our representation function, it is not just representing people who have voted for me, but also wider issues which impact the country and even perhaps the region. So then there are so many, for a country like Bangladesh, there are so many challenges. So where do you start? And to me, the most important challenge was saving lives. That I think it has to be the uppermost priority for any public representative. It's the best thing that you can possibly do. And so then I started looking at areas where I could engage, look at statistics, the number of deaths on account of various reasons. So there's, of course, tobacco, air pollution, climate change, disasters, these all came in. And then I started focusing on those issues. Although we are talking in context of policy, I think what I would put before policy is political ownership and political will, because that is your starting off point. And if you get that right, then the outcome in terms of strong policies is actually assured. And policy precedes legislation. So policy is where governments prioritize their needs. They attach the importance because there are so many other issues. So which issue is going to get the funding? So that sequence, political ownership, policy, and legislation. And when I look back, the impact of advocacy, the impact of coalitions of the willing has actually been immense. So information that was coming to me. And one of the greatest challenges we have is we have so many global agendas. How do we personalize the global agenda? How do we bring it to the individual level? How do we individualize it so that people can relate with that global agenda? And that's where the coalition, the advocacy came in. We can feel global warming inside here, I think, with all the lights flashing. So, and then the support that I had from tobacco-free kids, from Bloomberg, was phenomenal. Because what they were doing is sensitizing us to what the cost of inaction is. And then that was squared up with what is the benefit of action. And when you give those tools to any parliamentarian, trying to go to the Minister for Public Health or the Minister of Finance to allocate resources, becomes all that much easier. So that's how, if you look at the history of Bangladesh with regard to tobacco, it started off when we were one of the first signatories to the Framework Convention on Tobacco Control, 2005. I believe it was February. And right after that, that very year, there was a legislation. But as happens, the first legislation, you don't get it right. And then comes the next hurdle of amending that legislation, which is even more challenging than having the legislation in the first instance. So within just 8 years of passing the initial law, we were actually able to do an amendment where the definition of tobacco, including the smokeless tobacco, all of this was included. So the law was made tighter. But we didn't stop there. With the continued advocacy, we are now looking at the further amendment, which has actually gone up to the cabinet. So you can see within a timeline of just, 15, 18 years, a law has been enacted, it has been amended, and now we are going for a further amendment looking at designated smoking areas and removing them from the legislation, not allowing the tobacco lobby the space that they love to have, and they are extremely resourceful. And the other important thing, which I think I should share with you, is the cascading impacts. When you look at a country like Bangladesh and people talk about health, it is viewed from the lens of personal health. So, how many hospital beds we have, how many doctors, how many nurses. During COVID, how many ICUs we had, how many ventilator machines we had. But public health as a concept, which is the health of the nation, is never really prioritized or seen. It is always seen there. And because of the interventions that we were able to do in tobacco, we now actually have rules on clean air. Bangladesh has actually formulated that because that provided the impetus. That was the trigger. So you can see the benefit of advocacy in a particular sector, which then spreads across to all other layers of government, all other areas. So I think that was the trigger. That was the catalyst that we had. And when I look back, it's been an incredible journey. If you look at the success story of Bangladesh, I believe when the GHAI study was done in, was it 2019? No, 13, 17. Bangladesh reduced its tobacco use by 18%. One of the largest, one of the highest in the world. And you see, that of course is a very impressive outcome. But when you look at the genesis of that, where that started, that was through coalition. Now we talked about Zuleika in India, and then we have them also in Bangladesh. So the evidence, the support, the encouragement, and once you start the process, once public health gets prioritized, then it's a much easier job when we talk about water, when we talk about air, when we talk about sanitation and other challenges that we have. So I think the big takeaway from this is that when you start, it's tough, very tough, because the industry that you're taking on is very resourceful. They're very resourceful, they're very creative, their reach is very long, they have the networks in place. And at each and every step of the way, we faced challenges. As a parliamentarian, what we found out is that every year before we got engaged, there were letters signed by parliamentarians saying that, we don't want any tax on tobacco. We want tobacco to be unregulated. Why? Because it is providing employment opportunities for hundreds and thousands of people. And then when we had the alternative facts, when we had the evidence base, we were able to challenge that. So you see how important this coalition is. And I'm sure when probably in 10 or 15 years' time, we look at the public health, the policy evolution in Bangladesh, I think this is where it has all started off. And I think the fact that we were able to personalize a very important global agenda, if you look at SDG, so if you talk to people in someone in the village of Bangladesh and you say SDG 3, health for all, that doesn't mean anything. But if you're able to personalize that agenda, that's when you get their ownership. And I think that is what we were able to do. So policy advocacy, and prior to that, political ownership and political will to drive that process. And then the policy creating the context for the legislation to be applied. And I think that case of tobacco control in Bangladesh is a very clear-cut case. Of course, now as we move on, there'll be other challenges. But I think the foundation has been laid. The case has been made. And as I say, cascading impacts, it has acted as a trigger, as a catalyst. And I'm sure as we continue on this journey, and when we look at the development trajectory of Bangladesh, it'll be measured not just in terms of GDP growth, not just in terms of how much foreign direct investment has come in, but what is the elevated level of public health that we have in the country. Thank you very much.
Thank you so much, Mr. Chaudhry. It's been a pleasure to have you as a partner in Bangladesh, and it is indeed a success story in many ways, but certainly in tobacco control. So now I have the distinct pleasure to introduce our keynote speaker for today's event. and a respected colleague, Dr. Tom Frieden. Dr. Frieden is the president and CEO of Resolve to Save Lives, a nonprofit organization partnering with countries, communities, and organizations to prevent 100 million deaths from cardiovascular diseases and to make the world safer from epidemics. He is one of our partners and a longtime also tobacco control advocate. Previously, Dr. Frieden served as director of the Centers for Disease Control and Prevention and was commissioner of the New York City Department of Health. Tom, please.
Thank you so much. It's great to be here with you. Thank you, non-minister, but member of parliament, Chaudhry, for your wonderful remarks and for your vision, which has led to lots of progress. I want to start with a story from early on in my career. I was a tuberculosis control doctor, and I was put in charge of the tuberculosis program in New York City. And we fought very hard. We fought very hard to get an approval from then Mayor Dinkins to have the clinics renovated. It was a multi-million-dollar program. And after fighting with the budget office, we got it approved, and the clinics were going to be renovated. So these old, beaten down tuberculosis clinics were going to get not just a facelift, but a real full renovation, millions of dollars. And then election happened, and a new mayor was in, Mayor Giuliani. Now, Mayor Giuliani received a letter from the New York Coalition to Eliminate Tuberculosis. And that letter said, we demand that you affirm your commitment to renovating the tuberculosis clinics because tuberculosis patients matter. We must do this. And the letter went to the mayor, deputy mayor, commissioner, deputy commissioner, and then to me. I was the assistant commissioner. I didn't know what to say. It was the first week of the new administration. So I wrote a mealy-mouthed thing saying, well, this is a very important issue and we'll consider it, and up to the deputy commissioner, commissioner, deputy mayor. Deputy mayor saying, nothing doing, we'll renovate the clinics. Came back to me, commitment to renovate the clinics all renovated. The New York Coalition to Eliminate Tuberculosis was one man, Charles Ehlers, who wrote the letter on his manual typewriter. You know, it really shows what an amazing difference advocacy can do. And it's only with advocacy that we get the kind of progress that we need. We have long-standing health disparities, and they've been exacerbated nationally and globally by COVID. COVID has also, in some countries, including the United States, undermined some of the ability to have respectful conversations about how to move forward. These long-standing health disparities are in many different aspects of life, place being a major one. Here in New York City, the community where we're in right now has a life expectancy about 8 years longer than the community a few miles north of here in the same borough. Globally, countries vary by 20+ years in life expectancy. In terms of gender, unless we have empowered communities, empowered women leading efforts, we're not going to see the kind of progress we need in health, in society. To give you just one of many examples, we will not see an end to HIV without more female empowerment. Addressing disparities isn't just about fairness. It would be enough if we're just about fairness because we care about fairness. Addressing disparities is also about efficiency. If you want to make the most improvement, you deal with the greatest need. The way to make progress, though, needs to be very systematic and very thoughtful. Policy change is the royal road to progress. Let me give you just one example from the United States. There is a consensus that we should try to end child poverty, and child poverty is shockingly high in the US, especially in some communities, especially in some states. During the pandemic, there was an expansion of two widely supported national programs, the Earned Income Tax Credit, which gives hardworking people who don't make much money more money to top up their income and encourage them to work. What's not to like? And an income credit for families with children so that children can grow up healthier. That single law cut child poverty in half in the US. And sadly, as it has expired over the past year, child poverty is again rapidly increasing. It shows the power of policy to make change. But if policy is the royal road to progress, advocacy is the essential pathway onto that royal road. When we talk about progress and we talk about political programs or public health programs, one of the acronyms we use is TOP: technical, operational, and political. You need to have technical rigor, operational excellence, and political savvy. Technical rigor to figure out what's really going to make a difference, whether it's tobacco taxation or a measure to increase the availability of low sodium salts, or a measure to reduce the marketing of unhealthy food. You have to know what is technically supported. Basically, you have to be able to answer the question, if I do X, I will get Y. Operational excellence is also essential. Good management practices. It's not just about feeling good and getting people together. It's about organizing and being organized and communicating effectively. And political savvy isn't just about political will. A leader like our member of parliament, Chaudhry, can talk about what can be done. But for the rest of us, we need to think a little more analytically than we're used to thinking. We need to analyze who are the winners and losers in the status quo, and who are the winners and losers if our program passes. And how, to be blunt about it, do we activate the winners and address the losers? We also have to look at who are the deciders and who are the influencers. Who are the people who can make a change, and who's going to influence those people? It may be that a new government, a new minister comes in, and suddenly things that were unthinkable a week ago are inevitable today because of work that advocates have done for many years. Some programs can be done quickly with great results. Others take many, many years. I'll give you one example: drunk driving. Alcohol impaired driving in the United States killed lots of people, still kills too many people. And for many years, it wasn't taken seriously as a problem. It was seen as, I mean, this is almost impossible for us to imagine, but it was seen as almost funny. There were movies portraying someone weaving in and out of the street, and then mothers whose kids were killed by drunk drivers banded together. And with the combination of societal change and advocacy, political savvy, were able to influence the deciders and influence the context to make change. Making change means getting a stronger public sector, but also a vibrant civil society to push the public sector to do the right thing, to support them to get that thing done. And it requires rigorous monitoring. That's the triad: stronger government, stronger political, stronger civil society, and stronger monitoring to keep everybody honest, accountable, and on track. One of the major things that we must do in the US and globally, and in almost every country in the world, is a drastic improvement in primary health care. Primary health care means you should have a healthcare provider who you trust, who is accountable to you, who you can rely on for valid information, who you can see without financial hardship. And in most of the world, that's not present. In the US, that's not present. The countries that have gotten that right have used a virtuous cycle. We know of vicious cycles, but a virtuous cycle. They provide some more resources for primary health care. When that happens, people like it. It becomes more popular. Politicians notice things that are popular, and they provide even more resources. Those services get more popular. More people notice. They get more resources, and eventually you have a virtuous cycle of better and better quality healthcare, primary healthcare, as you've seen in places like Thailand and Costa Rica and many of the countries of Europe. And you reach, with that faster and faster virtuous cycle, you reach escape velocity. And what do you escape? You escape partisan politics. And soon, a strong primary healthcare system becomes not a partisan issue, not left, right, conservative, liberal, even civilian military, but a national issue. And the only partisanship might be different parties vying over what more they will do to strengthen primary healthcare more. So it's possible to have that kind of a virtuous cycle and address primary healthcare, because today, according to the latest information released this week, 4.5 billion people don't have adequate access to basic healthcare, and 2 billion people every year face financial hardship to get life-saving healthcare, including 1 billion who are impoverished by paying for their care. Now, sometimes we say, well, if all of this makes so much sense, why doesn't it happen? And there are many important reasons why it doesn't happen. You heard many of them from Member of Parliament Chaudhry that have to do with the commercial determinants of health. We talk about the social determinants of health, but there are also commercial determinants of health. The merchant of death companies, the tobacco industry, the alcohol industry, the junk food industry. They are not only selling products that kill people, they're also very actively trying to prevent governments from passing policies that will protect the people that their products are killing. There's another reason, though, why progress doesn't happen to the extent it might. We have to make things that are invisible visible, whether that's health disparities or secondhand smoke or a toxic product like trans fat that kills people without you knowing it in your food and gives you or your relative a heart attack. Invisible trends, invisible toxins, invisible progress, invisible risks of an outbreak about to happen. Invisible forces that are preventing us from making policies healthy. So the first step is to make the invisible visible. And the second step is to make what seems inevitable, what seems impossible, what makes a healthy future possible. We may think it's impossible. How could we ever live in a world without tobacco? How could we ever live in a world where everyone had a healthcare provider they can trust? We can't imagine that. It seems impossible to us. So after we make the invisible visible, we have to make the impossible that people realize it is possible. And once we do that, then we need to take the focused action, creating a healthy future through that kind of technical rigor, operational excellence, political commitment, through the stronger public sector, the stronger civil society, and the better data systems to keep everyone honest and on track. And I'll end with the story of artificial trans fat. It's a toxic product. It was added to our food supply not by any evil genius. People thought it was healthier in the 1950s. We learned that it kills people. It was estimated to be responsible for 500,000 deaths every year, heart attacks and other health harms as well. Gradually, and with help from Global Health Advocacy Incubator and other partners, and leadership of the World Health Organization, with technical rigor, operational excellence, political commitment, there are now 3.7 billion people around the world living in countries that are banning trans fat. It's gone from most of the world. And those populations account for about two-thirds, nearly two-thirds of the estimated consumption of artificial trans fat. And I'm hopeful that within a few years, it will be completely gone from the world. And if we think about equity, disease elimination and disease eradication are the ultimate in both equity and sustainability, because they are for everyone and forever. Thank you very much.
So much memorable from both of those presentations. Please join me in thanking them again. Tom, I'm certainly going to quote you. Advocacy is the essential pathway No, policy change is the royal road to progress, and advocacy is the essential pathway. You'll see that in many of my speeches going forward. Thank you so much. We're going to pause here and take a few questions. Both Tom and Mr. Chaudhry have agreed to take a few questions from the audience before we move on to our panel. So please, if there are questions, now is the time. Anyone? So much rich here. Did I see a hand over there? Please. Can you just stand up and say your name and ask your question, please? Mhm.
Hi, everyone. My name is Ben Weingrod. I'm with Management Sciences for Health. I was wondering if both of you could comment, particularly MP Chaudhry, since you are focused on climate change here at UNGA, the impact of climate change on health disparities and how advocacy to address both of these issues, how does that complicate it? Does it create new opportunities? What is the impact of addressing health disparities in an era of climate change?
Yes, we'll take a couple of them and then we'll have, please. Oh, great, thank you, Marty.
Thank you very much. This is Abraham from Motrade. My particular interest in WASH, actually. So basically the disparities at the ground level is mainly WASH-related disparities for achieving universal coverages, specifically in the least developed countries, huge. So when we're advocating for WASH, what will be actually the actual pathway to reach or to get the attention of the political leaders? Thank you.
Please.
Thank you. Fantastic presentations. My name is Bistra Zheleva. I work at Children's HeartLink. I lead our advocacy efforts. We work in Bangladesh in congenital heart disease, so I'm looking forward to talking to you after this. But my question is, how do we find funding for advocacy? We're a small organization and it's very difficult to fund these efforts. Thank you.
Good question. Thank you. Please.
Hi, John Klein with the International Pediatric Association. We're always challenged with bringing the issues like tobacco control to the primary care frontline health worker. So what can we do to have every frontline healthcare worker working with women, children, families, have what they need to know about discussing tobacco and secondhand smoke? And how do we bring that last mile to something that has no drug or technology, but requires a discussion with people in their communities? And specifically, how do we get that into the work that's being done on maternal and child survival? Because the frontline health worker in those settings talks about breastfeeding and immunizations, but not tobacco.
Thank you. We'll take a few more questions, but why don't we pause here?
So let me start with the question from you on climate change and health. The nexus is becoming clearer the more we go. In the past, we always associated climate change with sea level rise and displacement. But now I think the nexus connection is, that's very strong. And I'll give you an example. Dengue fever, the mosquitoes. I mean, we would normally have that probably about 2 months in a year. But now we still have it. It's been 3-4 months and it's now gone, it's spread to all over Bangladesh. The reason for that is, and this is science, as has been explained to us, is the ideal conditions for the virus to breed now exist in Bangladesh in terms of temperature. So you're looking at a temperature window of 34 to 36 degrees in terms of humidity, in terms of rainfall. All of these three are being caused by climate change. And when you have existing inequalities and access to health is sometimes a challenge, you can imagine what that does in the rural areas. In the metropolitan city of Dhaka, of course, we have hospitals. There also we have a primary healthcare, but not to take care of this. And whether it's COVID or any other public health emergency, your first priority is to control the disease to a level that your health system is not overwhelmed. We saw it during COVID in the States and also in other countries. In terms of how the government is handling that, I'll give you another example. So in New York, one of the major points of discussion is greenhouse gas emissions, fossil fuel. Any climate discourse you go into that is going to come in. So when we look at Bangladesh, our global emissions are 0.4% of total global emissions. So yet Bangladesh said no to 10 coal-based power plants, the potential for an investment of $12 billion. So why did we do that? Even if Bangladesh goes net zero tomorrow, it's not going to make a lot of difference in terms of its global footprint. We did it because of public health, because the fossil fuel is also driving air pollution. So these policy perspectives become more clear. So then you look at co-benefits. When I talked about the benefit of action, so by having one intervention, if you can get benefits, both in terms of air pollution and curbing emissions, then that's something that you do. But I think this is where we need to, I think, have more evidence. We, of course, have embraced the concept of health for all. In fact, there was an event in Bangladesh where the various ministries got together. So it was the Ministry of Environment, the Ministry of Health, the Ministry of Local Government, which controls, the municipalities and the mayors of various parts of the country. So now at least there is coordination. So we have asked the question, we have acknowledged it's an important access to make, and we will now move forward on that basis. Can I take two questions? There was another one on, and then
Sure.
I think there was one on resources. When you're talking about advocacy, financial resources, it is important, but it is not critical. I think if your intervention is targeted in terms of the champions that you're able to identify and you help them, I think you will get far more outcome. So this is almost a question of, it's not how many millions you are actually putting into advocacy. So here, I believe less is more, and more is going to be less in terms of impacts, in terms of your financial outlay. And certainly as long as you have that commitment, and money will not buy everything, money can't buy passion. So you will have to have individuals who are passionate enough, and just one individual can make a big difference. So I believe in that. So yes, it would be nice, to have more funds to raise awareness, talk about the benefits and the importance of public health. But in terms of making the changes in policy, in terms of political ownership, embracing the agenda, I think that can be done. I mean, as long as you have the evidence and the committed champions, that's possible. And
Thank you so
over to you.
much, Dr. Freed.
Thank you, and wonderful remarks. I learn from you every time you speak. Thank you. On the WASH question, I'm not sure I heard it entirely, but I will say that as with so many things, politics is very important, and WASH is enormously important. It has driven many of the health gains in the upper income countries for a century. If you come to New York City, you can turn on the tap and it's wonderful water and it's safe. You can't say that about most parts of the world, but that happened because of an alignment of winners and losers. It happened in the 1800s that business people in New York were worried that the lack of a safe water system was going to limit the possibility of the city to grow. And people were worried about their filthy water. And so they were able to influence Albany, which sets the laws for all of New York State, to give New York City, in what was frankly not very fair, the right to take over beautiful reservoirs all over upstate New York, throw farmers off their land, and build fantastic, pristine reservoirs that we benefit from 140 years later. So it does show the importance of being strategic. I wish those farmers had been better compensated, but being about who are the winners and losers. In terms of money for advocacy, completely agree, but I do wish there were more resources to support advocates and advocacy, because it is important. There's an interesting model for this, though, from Thailand, where there is a set aside of some of the tobacco and alcohol taxation revenue for a Thai Health Promotion Foundation, which then funds advocacy nationally. In terms of primary health care and how to mainstream tobacco control and other issues, we have to strengthen the primary healthcare system, and we have to promote payment models that reward maximizing health. Just encouraging people to act healthier or healthcare workers to do a better job is not going to work unless we change the default values and change the incentive system, so that when healthcare systems provide good cessation services or hypertension control, they're rewarded for it. And I will say, on the theme of equity, the world's leading cause of death is high blood pressure, 10.8 million deaths a year. And the likelihood that someone in a poor country has their hypertension controlled is less than 10%. The likelihood in the best performing systems of the world is more than 90%. So we have a massive equity at the world's leading killer.
Thank you so much. Okay, maybe we can just take two more questions. I did see one here. Okay, in here. Thank you. I'm sorry, say that? Okay, why don't, we're gonna have another chance to ask, to have questions at the panel discussion perhaps, but I do want to thank again, Dr. Frieden and Member of Parliament, Mr. Gardner. Thank you, I appreciate it. Okay, that was fantastic. Thank you, and thank you for the questions. So we're going to now invite two panelists, two really dynamic panelists, up to the platform to talk about the real practical role that civil society plays as good and effective advocates. So Dr. Ohor and Flor, please come up. So as they come up, Chika Ofer is the Chief Executive Officer of the Vaccine Network for Disease Control in Nigeria. And she has been a really effective advocate through the Global Health Advocacy Incubator. We're proud to partner with her organization to secure social and political will for equitable and sustainable financing for immunization and primary health care. And then secondarily, the role of youth is essential. And so we're delighted to have Maria Florencia Livia as the human rights lawyer from Argentina, and who is at the University of Buenos Aires Law School. She is an outstanding youth advocate and one of the founding members of Youth for Tobacco Control, a global alliance that we launched with youth from around the world. So please, Chika.
Good afternoon, everyone. I'm very happy to be here to talk about what I love. I love to tell stories. So get ready. I want to first of all congratulate everybody here. We are free today. We don't have many people wearing masks. We've overcome something. So let's just clap for ourselves for that. And today we're going to talk about the role of CSOs. CSOs, we are the voice of the people. We are the voice of the vulnerable. We are the bridge builders. We've interfaced with the government, we interface with the policies, we interface with the community. We see what is happening at the community level. So we know what policies are working, we know what is not working, and then we advocate when need be, and we become activists when we need to be as well. So thank you very much. Let me start with a story. 1995, June 3rd, my mother died from cervical cancer. And the reason that happened was because we didn't understand the information that came. It didn't present itself in the normal way. So she wasn't bleeding. She didn't have any of those things. By the time we realized that she had cancer, it was late. That began my advocacy journey. So today, we now have HPV vaccine. I wish it had come then. The story probably would have been different. So as an advocate, I'm very passionate. I understand what happens, and that is my driving force. In Nigeria, the National Health Act is the act that speaks everything you need to know concerning the vulnerable, the health for the vulnerable. But the provisions of the act that is so important is called the Basic Healthcare Provision Fund. It talks about primary health care in every community. Unfortunately, the government cannot do it by itself. Rather, what we have now is that we have primary health care in every ward. In FCT, we have 62 wards, and then we have access to health in only 62 wards. What is equity? So that means that if your primary health care is not part of that ward, it means you can't get primary health care for free. You have to pay for health. You have to pay to access primary health care. And that is the story of Nigeria. For us, I wanted to look at different things to talk about in terms of, we have policy advocacy, budget advocacy, but I said, let me just talk about community. During the COVID, we discovered that many people, many children missed out completely when it came to immunization. Then to catch up, the government started something called whole family approach, which is father, mother, children. We have one service to get at the primary healthcare center. And then we went to the primary healthcare center. The primary healthcare center was not ready to receive them. Then we called women who had small businesses around. And then we said, adopt a PHC. And they said, we can't afford to adopt a PHC. I said, no, it is not, you're not going to spend a lot of money to adopt a PHC. You're going to spend very small, 3, 4, 5 people can come together and adopt one PHC. Buy that BP machine, buy that sugar testing machine, do something. It does 2 things for you. The first thing it does immediately is that you start to look at that PHC and say, okay, my BP machine is there. And because my BP machine is there, then I will hold the citizens' accountability mechanism started. So, and then we started. They said, to make this work, what we would do? We said, include women. Include women. And then we included women. We built the capacity of women. We created awareness. We told them about that. And guess what happened? A woman called Biobac, a small restaurant. She decided to adopt a PHC. That particular PHC was not functional because thieves attacked that PHC every time. And then she adopted that PHC. As she adopted that PHC, she renovated the PHC. And that became a catalytic approach. Immediately she adopted that PHC, another woman adopted a PHC, another group of women adopted a PHC. And immediately that happened, they started holding those. We now developed the citizens' accountability mechanism to hold those. So at the end of it all, what happened? We have women who have adopted PHCs, put 500 naira, 1,000 naira to come together. And then immediately they came together and adopted those PHCs. The difference, there was a great difference. So now, what does that mean for us? What it means invariably now is that we have a citizens accountability group at the community level. Then we have budget advocacy. The budget advocacy with GHAI, Global Advocacy Incubator. We have budgets, the Nigerian budget. We want, what's the word? Budget, oh, yes, sorry. So the first thing is the Nigerian budget. The immunization budget has to be increased because 2 vaccines have been introduced into the Nigerian immunization space. The first vaccine is the rotavirus vaccine. The second vaccine now is the HPV vaccine. So because of this, it becomes imperative that the budget has to increase. Not only should the budget increase, the budget will increase, and then the utilization of the budget also is key as well. So we need the budget to increase, we need the budget to be released, and we also need utilization of that budget. All those things are done at the primary healthcare level. So thank you, GHAI, for making this possible. And that is what we are talking about. Then to make this also possible, we also need the media advocacy. The media, my sister is here as well, Dr. Vivian Hiekwazu. The media advocacy is also very, very important because it's through this that we create awareness of what the government is doing, how women are included, and how important it is that we save lives. Thank you, and thank you very much.
Hello, everyone. Good afternoon. It's an honor for me to be invited to discuss the role of advocacy in health disparities. As Yolanda mentioned, my name is Florencia Leiva. I'm a human rights lawyer from Argentina. And I'm here to talk about from a perspective of the youth. And for me, advocacy is, at its core, is about to ensuring that the right voices are being heard, especially when shaping policies that would have a great impact in our lives. And oftentimes, the people that are more affected by health disparities are not being heard. And these include the young people. Their voices are often neglected, probably because many decision makers don't connect the fact of the youth with some diseases that have a longer latency period to develop. For example, as the previous panelists were mentioning, cancer, diabetes, heart disease take longer, years, even decades to develop or appear. So politicians don't usually see the young generations as a targeted audience or someone to that urgently need to be taken care of on regard of those non-communicable diseases. But I invite you to imagine how powerful would be if those voices would be included when those type of policies are being discussed. If we started changing their behaviors at an early stage, we promote younger generations to eat healthier, have healthier diets, avoid the use of tobacco and alcohol, and we promote the engagement on more physical activity, we are preventing in the long run a lot of burden of disease that could be avoidable, and they will have a better future and, of course, a better present as well. And oftentimes, these young advocates who want to be involved in this type of discussions are not given the place to do so. And I met a lot of wonderful young people, young leaders, young advocates that want to be included. Last year, thanks to the Campaign for Tobacco-Free Kids, I have the privilege of joining an excellent group of young advocates from all over the world. We meet in a summit and we start discussing what was happening in our countries on tobacco control policies. Many of us have faced challenge to try to fight back the tobacco industry efforts of undermining our tobacco control policies that we were trying to implement or push forward at the national level. And immediately we discovered that we have a shared goal, something united us. And that's how we decided that we need to be allied. We need to be together in this task of pushing forward tobacco control policies that are effective. That is the main reason why we decided to found Youth for Tobacco Control, Y4TC. This alliance is a global movement of young advocates who are working on tobacco control at the national level, but united, we are promoting a safe space for sharing knowledge, sharing our challenges, strengthening our efforts as we go in our countries. And through these collective efforts, we are planning to move forward and inspire other young advocates to be involved as well. But this experience we have in the summit at the global level can also be replicated at the regional level. There are similar initiatives, incipient initiatives going on in different regions. For example, myself, I'm part of GHAI, that is an Latin American alliance of people under 35 years old promoting human rights at the regional level. And we do it so through tailoring messages through social media platforms, for example, Instagram. And we try to use simpler language to get more people on board and invite them to be part of our movement and try to fight for their rights in their countries and in the region. And so we are talking to a younger audience that we want for them to be included. And I'm talking about, I mentioned a previous example on tobacco control, but these same things are happening in the food policy realm. In Latin America, many of our countries are implementing front of package labeling laws, and we are seeing a lot of engagement of young audiences talking through social media channels, discussing how they are seeing the law being implemented in their countries. So we are acknowledging, we recognize that they want to participate in the discussion. They want to present their points of view. And in this sense, I invite you to think about how the younger generations have the potential to drive change. They hold the key for reshaping the future and of public health specifically to make it better, to make it healthier. And therefore, I earnestly encourage the leaders and global leaders to lend their support and empower those young advocates. They are the essential component in creating a healthier and more equitable world. Thank you.
I don't think there's a more powerful way to end today's conversation than hearing from a young person and talking about the importance of youth voices in driving improvements in public health. Unfortunately, we are at the bewitching hour, and our apologies, but both have agreed to be around in the room if people have questions. And please join me in thanking them for participating in today's panel. Thank you all for joining us. I hope you see this as a first conversation in how we can all collectively move forward to ensure that public health advocacy becomes a critical tool in improving public health outcomes and eliminating disparities. Thank you all and have a good evening.